essential. Understood? No? The kingdom. You are more of organism than your human body. You are more of organism than your human body, and that is the reason that the kingdom of organisms have to be preserved. Okay, by giving a probiotic, now you are not really restoring the kingdom. Remember this. If you thought that if I give a probiotic, you are restoring it, is wrong. Your kingdom has been formed because of the whole dietary habits that you went through. You know, with all what you're eating, with all the vegetables you're eating, all the fruits you're eating, all the milk you're drinking, you know, that is creating the kingdom. The kingdom is made over a period of time. It's made over a period of time. And one antibiotic destroys the kingdom. By the time it comes back, it takes a long time. And that adds to problems. So even if you have a small critical illness like a viral fever, if you pop in an azithromycin, it is creating havoc inside your body. It is creating havoc inside your body. You got the point what I'm saying? Why is that so? Because your kingdom gets wiped out. So it's not right to start azithromycin at the drop of your hat. It is completely wrong to do that for your own self, for your own safety. Because you are taking back your life years. Your longevity comes down as your gut microbiome gets spoiled. Clear on this? Right. Now feeding. So we are going to do everything very quickly. We will later on do everything very fast, very in detail also. But feeding. So feeding, there are two types of feeding. Either it's so whenever we say feeding now, it means special in the realm of ventilator induced ventilator on the patient on ventilator. It's called specialized nutritional support (SNS), which is divided into two parts: enteral feeding and parenteral nutrition. There are two types: enteral and parenteral. You don't say oral feeds here. Whenever you add a specialized nutritional support, it becomes feeding, enteral feeding. It may be oral or maybe even through the Ryle's tube. Clear? It's called enteral feeding. Otherwise, it's called oral supplements. Okay? Enteral feeding can be intermittent or it can be continuous. Is one better than the other? What do you think? Is one better than the other? Quick. There is no among these two. Intermittent and continuous, which is better? What do you feel is better? Continuous is better. Anyone who's saying intermittent is better?
Intermittent.
And so why do you say intermittent is better?
Insulin release and
correct. So ideally, if you ask me physiologically, the intermittent is better. What are you all doing? You're eating intermittently. No? You're not eating continuously. You don't have a tube in your mouth. All the time you're not eating. So it's always physiological to be having intermittent. It's always physiological. However, has it been proved that it is better? No. Has it been proved that it is better? No. Physiologically, intermittent feeding is the simplest feeding. It's actual feeding where your gut gets rest. You understand? If your gut has to work all through, logically you know the gut is not going to function well. It's going to get tired sometime or the other. That's why intermittent feeding is always logically better. You get a 10 hour rest in the night where your gut kind of gets ready. You don't keep eating in the night, right? You are the point. So the gut gets rest. So intermittent feeding is actually logically, physiologically better. However, it has never been proven to be superior. Why do we use continuous in our ICU? It is logistically easier. The nurse need not stand with the patient for 15-20 minutes making the feed and giving it to the patient. He just puts it and 6 hours she's okay. That's why we use continuous feeding. It's not because continuous is better. It is just because of the fact that it is just logistically easy for the nurse to actually go ahead with this. Okay. Initially they used to say continuous was better than intermittent, but that's not the scene as of now. Always feed the patient in a head-up position, and why is that so? Right. If you feed these patients in head-up position, the intestine moves quite better. You don't sleep and eat. So aspiration, however, is not linked. It is not linked that there is high amount of aspiration. It is not linked that if you put the patient down and say, I'm going to feed this patient will have aspiration. It is not. It's not been proved as such because of the fact that you have a tube in your mouth. Microaspiration can occur. But however, it is important to feed the patient in a head-up position. This is more so got to do with patients who are not on the ventilator. Correct? So, what do you aspirate? So, initially, there is a huge controversy on whether to aspirate or not. The capacity of your stomach is upwards of 2.5 liters. 2.5? You are passing 1000 ml through your saliva and another 1500 through your GI juices. So, 2.5 liters anyways going through your GI tract. You understand what I'm saying? That is anyways happening. But then, the capacity of the stomach is very, very high. Do you want to do a gastric residual volume? So, long before when we started, we used to aspirate. We used to aspirate the gastric residual volume. However, since the last couple of years, it's come to a condition that you don't need to monitor the gastric residual volume, specifically in which patients? In medical patients. So there are two kinds of patients, medical and surgical patients. But it cannot generalize this. You cannot generalize this. You cannot say, I'm now going to aspirate. Okay, there are patients in which you may want to aspirate because of the fact that you are suspecting that they may have problems. For example, you have a patient on bed number 1. She's having a problem with the GI tract. Okay, she has a problem. I will not tell the patient don't aspirate. I will tell her aspirate and see what it is. So you have to customize what you're going to do. You have to decide what is to do. You have a surgical patient who's coming in. A surgical patient has just undergone a GI tract surgery. Now these gastric residual volumes not having a problem is being studied in medical patients and not in surgical patients. So evidence-wise, surgical patients I will still want to do my GRBs. You understand? I still want to do my GRBs. So gastric residual volume aspiration. What is the limit? When will you say that this is too much?
150 ml.
500 ml. 500 ml is supposed to be enough. However, every institute has actually tailored it according to their requirements, but you must understand because of the fact that 1500 ml anyways is there in your GI tract and 1000 through saliva. So that way 500 ml is all that you need to have to call it, not 150 or 200. It's really wrong to do something like that when you say 150 ml. Okay, so what are we doing? What are we doing? Okay, we have tailored this according to the requirements that we want. Okay, we are saying that the GRB is more than 300 times, 2 times. Then they have to inform you. Okay, so they will aspirate, they'll say 300. We are telling, okay, you aspirate, no problem. If you want to aspirate, you aspirate. It doesn't take too much time to aspirate after 6 hours. Okay, they will aspirate. Watch and inform the doctor whether the patient receives total feed as recommended by the doctor. And what do you do with this? Further, what do you do? If you have got this 300 cc, what do you do? That's the question that comes is there. So let's see. If the GRB comes more than 300 for 2 times, what do you do? What do you think you should be doing? So you have a nurse comes and tells you first test 300 ml. What are you going to say?
Inform in the next.
Sorry?
Next. Inform for the next.
Inform for the next. Then here again comes 300.
Then continuous.
What do you do with that 300 ml?
Put it back.
Put it back inside. Are you sure about this?
Discard.
Discard, put it back.
Discard.
Absolutely not. Here you have been for 3 years. Okay, so what you first do, you tell the patient to be on the right side for a possible 15 minutes. Right side. Put the patient on the right side for 15 minutes. Use prokinetic immediately. First thing in your mind should be use prokinetic immediately and use which prokinetic?
Metoclopramide.
Sorry?
Metoclopramide.
Correct. And you have to use both together, 2 prokinetics. You have to see me what I do. This means the moment you have a gastric residual volume, I attach 2 prokinetics, erythromycin and metoclopramide. So you have to have both the prokinetics the moment you get a GRB. The moment you get a GRB, of course you got to figure out why. But the first thing you do is you add prokinetics. Which are the 2 prokinetics you add? Metoclopramide and erythromycin. The moment you have gastric residual volume, at the drop of the hat you will start both of these things. Correct? Here are things you will add. And then you think whether I need a transpyloric access, whether I need to actually pass a gastrojejunal tube from the top, a feeding tube, which goes beyond the jejunum. And why is that so? Because we know that the jejunal contraction still remains. If the gastric paralysis occurs, still the jejunal peristalsis still remains. This is known. And that is the reason that you should seek a transpyloric access. You are understanding what I am saying? So if you have paralytic ileus, say the patient is having a high gastric residual volume because the stomach is not propulsing it ahead. What we know is that even if the stomach is not propulsing ahead, there is a very high chance that the jejunum is still working very, very well. That is how our body functions. So if you take a transpyloric access, that means the tube is going from the tube through the duodenum and near the duodenum end, you will still be able to get peristalsis over there and you will be able to feed these patients. समझ में आ रहा है? So seeking a transpyloric access is something that we would like to do in these cases if the gastric residual volumes are predominantly remaining heavy. Then we'll reassess. Now you figure out why that is occurring. Why is the gastric residual volume going high? There are many reasons for it. One of the prime reasons that we have in intensive care, but especially in ventilated patients, is the fact that we use narcotics, we use opioids, we use fentanyl. Fentanyl per se is known to reduce the gastric motility as well as intestinal motility, and that is the reason that we want to modify or omit your narcotics in the first place. You will reassess. We'll reassess for electrolyte abnormalities. One of the commonest electrolyte abnormalities that you have in intensive care is actually hypokalemia. So hypokalemia. So you will evaluate for hypokalemia. And the third thing that you have in these cases, which actually causes gastroparesis, is which we started in the first. What we talked about. Now, it's the glucose control. Okay, it's the glucose control. If there's a variability of glucose control, you are likely to have gastric residual volumes to be high, causing problems. And that's the reason that glucose control becomes very, very essential in patients who are mechanically ventilated. So you need to reassess these patients the moment you have GRB. GRB is telling you something is wrong. You need to look. GRB doesn't mean okay, GRB aa gaya. No, GRB is telling you okay, there is something wrong. I need to figure out what's happening. So that is why we try to avoid the hyperglycemia. The more the hyperglycemia, more the gastric variability, the more the gastroparesis that will develop. And it's important to keep the patient's head of bed more than 45 degrees. How easy is it to do this head of bed more than 45 degrees? How difficult or how easy? Do you think it's easy? If I tell this is easy, it's not. And why I tell you it's not? Why it's not easy to do this? Because of the fact that the moment you put the patient on a head-up position at 45 degrees, the patient will start slipping downwards. This is not you or me sitting with support. Huh? It's not you or me sitting with support. You or me sitting with support, we have got tone, we have got power, we have got these patients are sedated on ventilator. Huh? The moment you put them on a propped up position at 45 degrees, the patient will start slipping downwards. So it's not easy. I mean, politically easy about 45 degrees, but it's not easy because you need to do a bed break. That's why you have the bed break on the knee. You know, and the nurses struggle to keep the patient at a head-up bed of 45 degrees. They actually will struggle to do this. Not only that, the pain factor of the patient increases markedly. Why is that so? Why is the pain factor increasing? You think you give the patient propped up, his pain will reduce? It will increase. Why? Not back pain. The entire fulcrum now rests on the sacrum. The entire fulcrum of the patient, the pressure of the patient runs on the sacrum. The pressure that is coming from the head and from the leg end is now concentrated on the sacrum, which will thus form a bed sore. So keeping the patient on a 45-degree angle is not easy. It's not at all easy. It will cause problems. And you have to be understanding what problem it will create, then only you will be able to look for it. If you don't know what's going to happen, you will not even understand what is to be done. Clear? So what are the points to remember? Initiate feeding within 48 to 72 hours. In our ICU, what do? The moment we have a patient who is on feeding, what do we do to these patients? We actually give them a starter feed. We start with the starter feed. We are just starting the feed. We don't need to really push the feed in a big amount. Nobody eats and become bodybuilders. Okay, you have to ensure that you are starting the feed. So that's why we had starter feeds. So in the first 3 days of your ICU stay, do not try to calculate calories, proteins and things like that. Just give starter feeds. And starter feeds in our ICU is a 500 kilocalories and a 30 gram of protein. This is what we are giving, starter feeds. The magic of nutrition occurs later on, okay? So avoid overfeeding. The important thing is to avoid overfeeding. Why don't we want to give that entire amount? Because you will cause overfeeding. Overfeeding can be disastrous. Initially, when you are ill, what is happening to your body? Your body is got a flight and fight response. When you are ill. When you are ill, what happens is your body releases what hormone, what catecholamine? Adrenaline. It is at a flight and fight response what? Adrenaline. So it releases adrenaline. What does adrenaline do? It stimulates glucose production. So you have an endogenous glucose production that is occurring in your body at the time that you are ill. That is the reason you also have stress hyperglycemia. The term for stress hyperglycemia. There is endogenous glucose production which is now supplementing energy for your body. So at this moment, if that endogenous glucose is happening, you don't need to give feed and cause overfeeding. Clear? So the first 3 days, what are we going to do in our ICU?
Start the feed.
Always look at enteral over parenteral nutrition. This is a pure exam topic. Very simple things. Exam topic. Everything in the exams will be asked like this. Everything exams. Okay. And you have to prefer enteral over parenteral. Complete exam topic. This is. The exam they are going to ask these exact very questions that I am telling you. Okay. Enteral and you always prefer enteral over parenteral nutrition. Okay. It's important to monitor the actual feeds delivered. That means how much you are prescribing is that being delivered. It's very, very important. Okay. Clear on this till now? So if I have aspirated, so putting the full story short, in nutrition, what am I going to do? When the patient acutely comes to us, I will ensure in the first 48 to 72 hours, I will start the patient on some kind of starter feeds which are called as trophic feeds. Trophic feed means I'm giving only 10 ml per hour, 15 ml per hour and very small amount of calories. That is called trophic feeds. Okay, trophic feeds are better than full feeds. Okay, that is because of endogenous glucose production. In the meanwhile, I'm going to expect that a patient on narcotics, patient is on opioid, patient on this, there is going to be gastric residual volume. If by any chance after 4 hours, 6 hours I aspirate, in our ICU we aspirate after 6 hours, though it will be selected in which patients to aspirate. Within 6 hours when they aspirate, the nurse comes to you and says, see 150 ml has come, you say don't bother about it, give it back to the patient. So what I'm going to do, that 150 ml that comes out, we will give it back to the patient. We will not discard it. If you discard it, you lose that calories, you lose that proteins. It has to go back inside. It has to go back inside. So they have to feed that back inside our patient and then check after 6 hours again. Don't tell them to check after 1 hour. Okay. And then if it again comes very high, more than 300 ml in our ICU, although the gastric residual volume is 500 ml all over the world, and what is mentioned in the notes are 500 ml. I would say 300 ml in our. We are not Americans, we are Indians. Maybe we have a small conservative stomach. So 300 ml. Clear? So 300. If it comes back at 300 ml, now at this moment I will try to figure out what's happening and still feed that 300 ml inside. I will start erythromycin, I will start Perinom. Erythromycin single dose 500 mg, Perinom 10 mg TDS. I'll start this erythromycin and metoclopramide. Give the patient a left lateral, right lateral position so that he can actually empty the stomach. Okay, empty the stomach, keep the head elevated, and wait and watch, and check for potassium abnormalities and narcotics. Okay, then if the patient still has multiple episodes of gastric acid volume being high, then I will hold the feed because there is something wrong. The paralytic ileus is not subsiding. I will call up the gastroenterologist and try to put a feeding jejunostomy, a feeding tube, so that I can feed this patient. But I will still try to do enteral nutrition in preference for parenteral nutrition. Clear on this? Only when all attempts have failed in enteral nutrition delivery, after 5 to 7 days, I will want to start parenteral nutrition. Clear on this? So I will not do anything till I get enteral or this coffee combo. Clear on this? समझ में आ रहा है? I will not do parenteral nutrition unless 5 to 7 days have passed and all attempts have been done for enteral nutrition. Clear? Analgesia here. All patients in the intensive care unit require analgesia. I explained to you. Okay? Very important. And pain comes on various sides. It can come from lines, it can come from tubes, it can come from the position that the patient is. There are so many things that can occur. Pain from bed sores, back pain from the way the patient is put up, unaccustomed positioning. Clinical features. Now there are certain clinical features that point towards analgesia. Certain giveaways, very simple giveaways. What are the clinical features saying that the patient has got pain? So you can have tachycardia. Tachycardia is one of the common causes. Anesthetic is working in intensive care unit. They know that tachycardia can be part of pain. You know, it can be part of the pain. Sweating, very essential. Sweating. A person may not have tachycardia but may have sweating. The third thing is facial grimaces, indication like limb movement over a painful part. Very important. Hypertension, very high blood pressure. One of the commonest causes. In fact, the common cause for IC when the patient has IC hemorrhage and hypertension is actually just pain. If the patient has a headache from the IC bleed, you will not go and treat it with NTG. Give them a paracetamol. He'll become fine. That's why always when a patient has the IC bleed, always keep a analgesic on board. It's very often you notice that when you give an analgesic, the requirement of NTG comes down, the requirement of antihypertensives come down. So analgesia, very important. Okay, hypertension can come because of that. Increased sedation requirement. So don't keep on increasing the dexmedetomidine because the patient is moving. No, it's wrong. It's completely wrong. When what you're doing is completely nonsense. That a patient is actually is moving about, thrashing about, not okay. The problem may be pain, and 99% of the problem is usually pain. You don't realize that you need to not increase sedation and knock off a patient. Vecurone is not the treatment for analgesia. That's what you did the other day. So you're not supposed to do that. It's actually criminal to give Vecurone and not give analgesia. It's criminal. If the patient has got pain and you're giving Vecurone to just stop from moving, it's completely wrong. It's criminal. Okay, you can't do that. It's very essential that you understand. So if your sedation requirement today was 4, you have Dex 7, tomorrow has become 8. You must understand somewhere you missed out something. If a person was stable on a 4, he should have been stable on a 4. If you have gone from 4 to 8, means there is something that you're missing somewhere. Okay? Right? So modes of analgesia. So importantly, you must understand that when you're using analgesia, use it in different modes if it's possible. Don't just use it as single particular class of medicines. So it could be epidural, could be NSAIDs, could be opioids, could be nerve blocks, infiltration and plexus blocks. So you want to use all kinds of analgesia that we have for these purposes. It is important to use as much as possible, especially this is in the realm of trauma. For example, you have a patient who's got a rib fracture and comes to you and you want to actually keep this patient on the ventilator. At that stage, it's very essential to actually put an epidural block and at the same time supplement with paracetamol and opioids in such cases. Multimodal analgesia actually prevents you from getting into other problems. Sedation. Why do you require sedation? You need the patient to be comfortable, and not only that, you have a sleep-wake cycle. When a person is in the intensive care, the lights are on all the time. So it's important that you help them in this aspect. How do you help them in this aspect? When you go to sleep, what do? You switch off the lights, you put the room silent, and then you go to sleep. You don't put the TV on and full blaring, or you don't hear music in a big amount, and you don't do that. Similarly, in our ICU patients also, because of the unaccustomed place that the patient is on, with so many people around, so many people looking at them, it's very difficult for a person to sleep. So that is the reason that what we do in these cases, we switch off the lights, ensure that the sound is less, and we give them some sedation in the night hours. So that gets the sleep-wake cycle proper. It will reduce the stress, anxiety and strain that the patient has. It is known that if you were to get the patient to be sleeping well, the next day morning interleukins, cytokines, all this are actually coming down. So that is the way you treat these patients. You have to sedate them. So in the night, if the patient is not sleeping, that is not the answer. You have to ensure that the patient is sleeping. You have to ensure. Okay, and these patients require pharmacological help to actually get to go to sleep. It will provide amnesia and remove all the bad experiences that this patient has from the intensive care unit. Intensive care unit cannot be a good experience. It is not possible to have a good experience in the intensive care unit. You are going to have bad experience. It's important to give some amnesia. And that is the reason that these patients should be, you cannot say, I felt very nice having a ventilator in my mouth. It's not possible. It is just not possible. That's why you need to give them magnesia, and you have, and it's also very important because you need to give them comfortable ventilation, and that is the reason you want to sedate them. So, can you have a single ventilated patient without sedation? You can't do that. It is really, really wrong to do that. Okay, it will also reduce oxygen consumption on a physiological level. The oxygen requirements will actually come down. So, this is very wrong. What you all do, and you are doing this very regularly. It's very wrong to do something like this. Okay, and you are doing this regularly. That's the reason I actually went ahead and I'm teaching you all these things. Okay, you are not supposed to do this. Start 255 ml per hour and then titrate. But it doesn't work like that. It doesn't work like that. Who's going to titrate that? Are you going to titrate it? No. Who's titrating it? It is the nurse who's titrating it. You are not coming back and saying kitna ho gaya. Are you understanding what I'm saying? If you say start Dexam 224 ml per hour, but what is that? That is not the way you are supposed to manage these patients on sedation. That is not the way. How do you do it?
Bolus, first do some bolus and
That's what exactly what I've written, but that's not the way you're supposed to manage. I'm saying it's not the way you're supposed to manage. How do you manage it? Any idea?
So initially it should be given at a bolus dose, one max.
Okay, that's what she's also saying. But this is not the way you should manage. How do you manage them? So it's wrong to manage this way. The way you are telling it is very wrong to manage this way. You have to use a guideline, an algorithm, or a protocol. It is very wrong to do that because the nurse is not going to titrate that sedation. The nurse is not going to titrate that sedation. The nurse will just take some 4 ml and leave it the way it is. So what you're supposed to do is you have to titrate to a defined endpoint. Defined endpoint. Get me the chart, please. The flow chart. Get me a flow chart. Any flow chart.
Charting.
Titrate to a defined endpoint. So as doctors in the intensive care unit, you have to titrate to a defined endpoint. Okay, and this is very, very essential that you define it to the what is the endpoint that you look at. It's very, very essential because that's what the nurse does. That's what the nurse does. Okay, so what is the defined endpoint? There has to be a systematic tapering. This will ensure the systematic tapering. So if you are given a high dose, it will ensure that she tapers it. If you are given a low dose, it will ensure that he goes up on that. You know, the systematic tapering. Daily interruption. The other tenet when you have sedation is daily interruption. And when is this daily interruption done? Morning hours at 8 a.m. Okay, 8 a.m. daily interruption when the whole group is there awake and alive. So that is the reason that the clinical practice guidelines also mention that you have to sedate to a goal. Okay, you have to sedate to a goal. That is why you need to use a sedation protocol. Because what does the sedation protocol do? It actually reduces direct drug costs, reduces ventilation time, reduces length of ICU stay without any change in mortality. Without any change in mortality. And that is the reason that you need to have a sedation protocol in place because over sedation is extremely bad. That's why you need something like this. So when you look at the chart, when you're actually putting every chart in intensive care unit in every hospital across the world, we'll have a sedation score. So what we have using over here is called as the Rickman Agitation Sedation Score. It's Rickman Agitated Sedation Scale. This is what you're saying. There are many scales. There is Ramsay's scale, there is Ramsay's score, there are so many scores. But what we're using? Rickman Agitation. Now in Rickman Agitated Sedation Score, there is a plus and a minus. Okay, there's a plus and a minus. If you see very carefully, there's a plus up to 5 and a minus up to -5. So what we need to have is a patient between 0 and -5. Read it out. What is 0 and -5?
0 is alert and calm, -5 is unarousable, no response to voice or physical.
So what is 0?
stimulation.
What is 0?
Alert and calm.
What is -1?
-1 is drowsy, not fully.
But what happens when it's in -1? The moment you tap the patient wakes up. The moment you tap the patient, the patient wakes up. So what you require, you need to tell the nurse that you have to sedate to RASS 0 to -1. When I write sedation orders, I write it like that. RASS 0 to -1. You have to write it like that. So all of us sitting in the intensive care unit should realize that unless it has been differently coded, you have to ensure that the patient is at a RASS of 0 to -1. And if the nurse comes and tells you कि अरे sir वो उठ रहा है बहुत जोर से उठ रहा है, मैंने तुमको क्या बोला है? Maintain at 0 to -1. That is where it should be. So increase if required, decrease if required till the patient is at that. You have to titrate. So it's wrong to have a person at 4 ml and 4 going on. That means he didn't require that 4. You know, it would have been much lower than that. You got the point. Similarly, if the person is just, it's wrong to go to the patient and then increase it because he's woken up. Okay, so there are various protocols to do this. If a person is on dexmedetomidine, for example, let me tell you, if it is dexmedetomidine and the patient becomes very agitated, what do you do? Yes, and what do you do? Patient becomes agitated, patient on dexmedetomidine, what do you do? You have started at 4 ml per hour, you do not explain the scale, you just told 4 ml per hour, chalu kar do. Obviously, nurse will start with those exactly what she is doing. She will put 4 ml per hour. Now, you are on the other side of this ICU and suddenly the nurse comes to you, sir, patient will try. And there are 2 people holding the patient. What do you do? Okay, anybody else? Kadapa, what will you do?
Sir, add another sedative.
That will not allow him to sleep. How will you do it? I'm asking you, what is practically you are doing here? Tell me.
Sir, otherwise I will give the bolus dose of dexmedetomidine.
Completely wrong thing to do. Anybody else? Huh?
Some other.
So I need to give an agent that will not cause problems with this patient as a bolus. I can't increase the dexmedetomidine and think that he's going to sleep immediately. That's not going to occur. In fact, that will be harmful. People off the line, people off the tubes, and problems might occur. So what do you do in such cases? You try to use a second sedative agent in this place so that the patient sleeps off. A second agent which can be given as a bolus, which will act very quick. And one of the simplest agents you can use is Cialis. Okay, haloperidol. Just give him a shot of haloperidol immediately. Let the patient sleep, and meanwhile up titrate your dexmedetomidine to again a goal of RASS 0 to -1. There are this to a goal of 0 to -1. You understand? 0 to -1. See, this is trial sedation score, but I want to keep it 0 to -1, 0 and -1. I don't want extra sedation in these patients. Okay, 0 to -1. Okay, there are instances where you require -3 and -4. Which are those instances? When a patient has got head injury, patient has got raised ICP, patient is you don't have prone ventilation. There I don't want 0 to -1. I'm going to tailor it accordingly. See, if I have a patient, for example, who have just been intubated in that side, who has got diffuse cellular hemorrhage and an ARDS. I don't want the patient to wake up in a minute or for 1 minute also, because I am not concerned with the spontaneous breathing trials in this patient. I'm not really not concerned. And my spontaneous breathing trial is going to come in and going to start getting him off those high peeps, isn't it? So when the patient is on high peepinol, I don't want the person to be sedated at 0 to -1. I want him to sleep. So I will say -3, -4. You got the point. So the score has to be decided by the person or the doctor who is actually working in the intensive care unit. And you should think about it why you are supposed to do that. Okay, so RASS, clear on this? Very clear on this, that's the score. So various ways to do these things. But the way we are doing is the way just now I explained to you. Clear now, Madhapa?
Yes, sir.
You can't do anything different from that. So there are many pain scales. Now what we talk about sedation. Dexmedetomidine is a sedative analgesic. Dexmedetomidine is a fentanyl is a analgesedative. So the effect of pain relief will be much higher with fentanyl as compared to Dexem. So it's very wrong that the person is thrashing about it just increasing Dexem. He may be having pain, you increase your analgesia. And that is the reason you need to understand what is why you require analgesia. Okay, so in patients who are actually down, who are on the ventilator, there is something called non-verbal pain scale. Open it. It's called non-verbal pain scales. These are non-verbal pain scales that are there. Non-verbal pain scales are those scales that make you understand as to how this patient is behaving. Can you see non-verbal pain scale? So there is a non-verbal pain scale on the back of your sheet. Non-verbal pain scale. Which actually tells you with respect to posture, hypertension, sweating, and tachycardia, which tells you what this patient is about. Non-verbal pain scale. You are actually supposed to go to that and figure out what pain scale the patient is on. Okay, you're supposed to patient having pain. This is the pain scale. There are 2 of them on this. Which are the 2 of them? There is non-verbal pain scale for a person who is actually on ventilator, and there is a visual analog score which is called as the ladder pattern. Okay, besides it, can you see that? This is the visual analog pattern. Can you see this? On a score of 10, how much is there? On a score of 10, how much is the visual analog? This can be by faces also. Okay, where's and you have NVPS. You must know your chart. Now you must know your chart. If you haven't, please go back and read it once. Okay, non-verbal pain scale. So it's important to have the pain threshold in place to understand what it is. If the patient is delirious and stressed out, many of our patients can have, the problem may be sleep deprivation. The environment itself is very horrible. The third thing is extreme anxiety and delirium, and adverse drug effect and pain. Okay, so these are the things you should check out. And I think one of the main things I have somehow missed out over here is hypoxia. Okay, so when a person is distressed and delirium, you should have these things in your mind. Is it related to pain? Is it related to distress? Is it related to sleeplessness? Is it because of hypoxia? Or is it because of any drug that I have given? You must be able to tell that. So delirium when you're writing, These things should be marked out. There's delirium. Is this, for example, bed number 3, Niharika? You should have written all these things. Is it hypoxia? Is it pain? Is it sleep deprivation? What is it? Because I have no idea what to do with this patient now. You know, so if the situation was he has not slept yesterday night, if the sleep it's not slept deep yesterday night, I know what the problem is. The problem is sleep deprivation. You got the point, huh? So that way the treatment becomes very, very important. Other things that we can actually look at is hormonal effects that can come in, catecholamines, growth hormone, prolactin. So these all will cause this kind of an issue. Ischemia, fluid electrolyte disturbance, and a decreased wound healing. So all these things are part and parcel of analgesia over here. What is paralysis? The drugs that are used for paralysis are scoline, vecuronium, rocuronium, and atracurium. There are only 4 drugs that we are using in our ICU. It's a very simple thing, paralysis. If a person is moving about and thrashing about, giving Vecurone on its own without sedating the patient is a crime. Okay, so we do use paralysis for our patients, but importantly, it is used only for a subset of patients in which I don't want the patient to trigger the ventilator at all. When I say trigger the ventilator means the patient should not breathe at all. Now, which are those patients? Patients on poor ventilation? No. Maybe, maybe not. Okay, so you may sedate them to an extent of RASS -4, -5. They may not require paralytic agent. Okay, then but you can. That is one of the patients in which you may consider giving paralytic agent. Then
ARDS.
ARDS. Anyway, ARDS is the beam that is high. You can't have the person on paralytic. You can't have the person on paralytic on without paralysis. You need to have the patient on a paralytic drug. Third, when you're about to intubate, you're about to intubate and you're doing all your assessments on the lungs. You need the patient to be actually paralyzed. Okay, so immediately when you intubate to Vecurone, and that is the only moment that you should actually give Vecurone and check what is happening to your patient. Like to this morning's patient, we gave paralytic agent, we checked what the patient is, what is the compliance, what is the assessments, what is the recruitment, what is the RSVR, we are not RSVR, what is the everything we check, plateau pressure, driving pressure, we check. That is the time I checked it. Okay, so only that time you require paralysis. As much as possible, it should be used only for defined purposes, of which one is rapid sequence intubation, for bedside procedures like endoscopy, for critically severe ARDS patient that has been ventilated, with modes like PCIRV. For example, you have a very different mode. You are breathing at an inspiration, expiration, when inspiration is small, expiration is large. Now, if I turn that to 2:1, it's not possible for your brain to understand this. And the diaphragm will not work like that way. It will not be able to synchronize. That's the reason when you are using mode like PCIRV, which means pressure control inverse ratio ventilation, you will probably need something like that, because it reduces oxygen consumption, and it is important to use it only when it is essential. Only when it is essential. So what does this say? If you are sedated to go, you may not require it. Unfortunately, what happens is you are not sedated to go, the patient starts thrashing about, and the first thing that comes in your hand is Vecurone. Huh? You got the point? Huh? So it's very essential to use it sparingly, extremely sparingly, to the extent that I never want the patient to be on an infusion of Vecurone. I never want it. Very rarely you would have noticed that a patient is on Vecurone. We never want to do that. We don't want to put 2 mg 6 hourly. Very rarely you would have noticed that 2 mg 6 hourly, 2 mg 2 hourly. Very rarely. As much as possible, we don't want these patients to be on all of these things. Clear? Then use paralysis only with a neuromuscular monitor. We normally put those monitors when you are using paralysis. Ensure the patient is sedated before paralyzing. It's wrong to paralyze a patient without sedating. It is important that you tape the lid or close the eyes so that the patient does not keep the eyes open, because if you paralyze the patient, the eyes will be open and eyes will get dry. The biggest litigation that you can have with a person that comes in after ARDS is actually this, corneal ulceration. Okay, so if the person you have kept on the mechanical ventilator, he does well, goes home, develops a corneal ulcer, it's a grievous injury, patient can come back and sue you medically because he didn't come with a corneal ulcer. Clear? Huh? It's a grievous injury, so you cannot have that. Okay, ensure ET tube tracheostomy is in the right place before paralysis. Very essential that you confirm carbon dioxide, EtCO2 before you actually start paralytic agent, and ensure all the drains, lines and tubes are secure. Okay, thromboprophylaxis. So we did discuss last time about thromboprophylaxis, so we'll run through this quickly. All ICU patients would require thromboprophylaxis. Pharmacological, there are 3 types. There is heparin, which is unfractionated, low volume heparin, and there is heparinoids. We don't use the heparinoids. We can also use mechanical graduated compression stockings that we talked about, and pneumatic compression devices. Alright, a combination is said to be better than the other in those highly hypercoagulable states like cancer with sepsis. In those hypercoagulable states, cancer with sepsis, it seems a combination is always better, but pharmacological is always better than mechanical thromboprophylaxis, as we discussed last time. Daily assessments. Every morning when you are actually taking around, assess the calf muscles. Look for swelling in the calf and difference in the legs. You are still not doing it. You are still not doing it. None of you are actually doing this. You are not looking at the calf muscles. You are not looking at the difference in length of size, because when I come in, I am picking it up. I want you all to pick it up. It's important. You are not doing this. It's very essential that you look at the calf, not just because he's a case of BDD. No, every patient needs to be checked. Both the sides. I always open the leg. I always check both the legs. And you've seen this. Every time when I come on my rounds, I open the legs, I check the pulse, I move my hand all through the legs. I'm looking at whether the leg proportions. It's a very simple test to do, but it's important to do it on a daily basis. If you do it on a daily basis, even when you're 70 years old, you'll do it. If you don't do it, you'll never do it. Clear? So daily assessment is very, very essential. So when I say thromboprophylaxis, you should be able to, on the background, assess for thromboprophylaxis, assess the risk in these cases, and that's why we fill out these thromboprophylaxis risk assessment forms. That's why we fill the risk assessment forms over here. Correct? Head end elevation, extremely important topic. And all patients should have an head end elevated. However, 30 to 45 was what was prescribed. We can't do it at 30 to 45. We try to do it at 15 degrees at least. How do you know it's 15 degrees? Because at the end of the bed there is a goniometer. In the goniometer it shows 15 degrees. From the hip it has to be 15 degrees. Okay, very important to know that. Why? Because it says it reduces the chances of aspiration. It is proven to reduce mortality from ventilator-associated pneumonia. And enteral feeding is tolerated better. Nobody sleeps and eats. Right? It is tolerated better. Alright, what about ulcer prophylaxis? As we said, there are few places where we need ulcer prophylaxis, and one of the main important places is ARDS coagulopathy. Okay, ARDS coagulopathy and mechanical ventilation and therapeutic anticoagulation. Okay, we will use pantoprazole for all our patients. We will use pantoprazole for all our patients, though there are head-to-head comparison between sucralfate and paracetamol. Sucralfate showing a slight edge when it comes to ventilator-associated pneumonia, and ulcer when bleeding disorders, pantoprazole has a slight edge. So if I have a patient who is on the ventilator and I have a high incidence of having VAP, sucralfate would be a good judge. But if the person is a patient who is having a high incidence, who is going to bleed, for example, coagulopathic, pantoprazole is what I'll start. That's the difference when I'm going to use sucralfate and paracetamol. A normal patient lying on the ventilator with ARDS, probably sucralfate would be the way. But if a patient is having INR that is elevated, PGD that's not okay, high chance of coagulation disorder, steroids, pantoprazole will be the way. What I'll argue. Clear? Glycemic control, very important. If you don't do it, it increases infections, poor wound healing, gastric feed intolerance, poor utilization of nutritional support, and low glucose would actually increase mortality. Try to maintain the sugars between 110 to 180. This is what we want to do. We want to keep it above. It's very important, and that's why we use our 7G protocol. Skin treatment. When I say skin bed sores, it's very essential that we keep our patients in a mobilized condition. What is the frequency of mobilization that we need to have? What is the recommended frequency? 2 hours. 2 hours is what is required. So first you assess the risk of the person that the patient will have bed sore. The moment you feel that this patient has got a bed sore, for that matter, every mechanical ventilated patient will have a possible bed sore. What we have introduced in our hospital is to have a clock. So there is a clock that you place beside it. That clock actually shows what position they have to be at. So you at a glance should understand this patient should have been in left lateral. Why is he not left lateral? And you should immediately tell the nurse keep in left lateral. You got the point? So that is what you have to ensure when you are on your rounds. Okay, immobilization is, if these patients are immobilized, they're nutritionally down, the skin breakdown can occur, very severe skin breakdown can occur, they're edematous. If they're edematous, what is going to happen? Skin breakdown again. Skin breakdown again. So you can't have a patient in intensive care not being turned, because all these problems are there in every patient. Your skin gets soiled, patient is inside the intensive care passing motions and not getting clean. It takes some time, 10 to 10 minutes it takes for it to clean. Okay, so skin soiling is occurring on a regular basis. His sweat is there on his body which is not being wiped. On the back. You and me, the moment we feel sweat, we wipe ourselves. They are not able to tell you only that there is sweat on my back. When you see wetness everywhere, that is when they decide that he is sweating. You know, so there is skin soiling that's occurring. Points to remember is that adequate turning of the patient is very essential, and this is very dangerous in intensive care unit patients because they may drop blood pressure, they may get the tubes coming out. So it's very scary actually to see patients being moved very aggressively also. It has to be done very carefully, aggressive turning. Early position changes is what is actually recommended, but we are doing at least 2 hourly. Watch for pressure points. Watch for pressure points, and let's say pressure points. Which are the pressure points on a patient who's lying down? The occiput, the shoulder blades, the sacrum, and the heels. These are the pressure points that you have when you have, and it can vary when it's in lateral position. Watch for skin color changes. The moment the patient's skin colors and you press, and the skin does not blanch like the way it should blanch, means you have gone to grade 1. You getting the point? Means if you have a person being on one position, you turn it, and the patient this side is all nice and pink and this side is slightly blanched out. and you press it, it doesn't change color. That means you're a grade 1. This patient's next step is skin breakdown. Clear? Huh? So non-blanching skin is actually is grade 1 pressure ulcer, which can then go ahead and become problematic. Powders and lotions are used to give skin integrity and tone, and it's important to avoid tight restraints. Very wrong to tie the patient like that. Very wrong. If you tie the patient like that, the next bed sore is where? In the elbow, not in the hand, in the elbow. Your elbow develops a pressure sore, which is very difficult to heal because it's a mobile part of the body. Okay, so it remains like this, you will develop a pressure sore, pain. So whenever you, even if you want to tie the patient, the body or taking tight, there has to be some leeway to move the hand themselves. Okay, it's very important. Use of something called as Braden score. So if you look at Braden score, this again is over here. Okay, which actually tells you the incidence of having pressure sores. Now if you, the Braden score is the Braden score written over here. So it says, what is the patient's sensory activity, what is the motor activity, what is the mobility, what is the nourishment, okay, and what is the friction. So friction, shear, mobility, nourishment, all these are actually scored, and then a point is created. The Braden score gives you an estimate of the patient being high risk for pressure sores. So when a new patient comes in, you check the Braden score and say this patient has got it, and tell them to put that clock over there. You're understanding? Why am I telling you about Braden score? As an exam topic, you should know all of these things. Okay, shear injury, mucose pressure, friction, shear, and nutrition. These are the various points of Braden. Okay, the Braden score is done so that the moment you see the Braden score to be elevated, you tell the nurse, boss, you put the clock there. This patient has to be turned aggressive. For that matter, every patient is on the ventilator will have a Braden score that is in the higher. Clear? So Braden score. Remember Braden score, it can come in exams. These are all basic things that come in exams. Okay. Braden score for gradation of whether these patients require bed sore, require turning and aggressive mobilization. Other thing is bowel care. Ensure cleaning of the bowel at least once a day, clearing of the bowel. Skin surrounding of the anus has to be dry, soil is immediately has to be cleaned. If the rectal tube is in place, inspect the site of exit. And fecal color for bleed. If there's a rectal tube, just don't leave the rectal tube there. Is there bleeding? The question that you should ask is there bleeding? Okay, the rectal tube can cause bleeding over there. If there's abdominal distension, timely gut charting is very important in case. Okay, bowel care. Indwelling catheter. Very essential that every single day you sit in front of the patient and when you're taking around, decide whether this catheter is required. The day you feel that the catheter is not required, it should be out. It should be out because it reduces infections, inflammations, and iatrogenic complications. Very essential. It applies to, so when I say catheter care in your IC, in your indwelling lines, you are looking at what all? You're looking at all the catheters that are there in your body. You're looking at intercostal drains, you're looking at abdominal drains, you're looking at urinary catheters, and you're looking at ventricular catheters, you're looking at peripheral venous catheters. How long can you keep peripheral venous catheters? On an average, it is said to be kept
7 days.
There is no time limit. As per latest guidelines, there is no time limit for peripheral venous lines. Though we may want to change it according to what our requirements are. In our hospital, we are looking at 70 to 96 hours. Unfortunately, it is changed to how much of a time you want to keep it till you have a problem. So you can keep it for how long ever you want. Okay, peripheral venous catheters. De-escalation of antibiotics. Remember, this narrow spectrum antibiotics are better than broad spectrum. You have to ensure that you de-escalate antibiotics as quickly as possible. I like to come down on the antibiotics as quickly as possible the moment we feel that the patient is getting better. More days of antibiotics does not ensure that the patient is getting better. There are huge cost implications to antibiotics and it becomes very unsafe, very unsafe if you do not stop those antibiotics. It's very unsafe as we told about these things. Lesser the better. Lesser the better, always. Alright. So, what is going to happen? Another thing about ventilator patients is you're going to get him off the ventilator quickly. And that is the reason, maximize the mobility. Maximize the mobility as much as possible. Every single day patient on the ventilator maximizes mobility. Maximize it in whatever way you can. If you have a chest physiotherapist, tell them to limb physiotherapy. Do limb passive physiotherapy. Mobilize him. Even if he is paralyzed, even if they are sedated, let them do passive physiotherapy. The center I worked in had robotics. They used to put the patient on a robotic arm and make the patient walk. Even the patient was paralyzed. Okay, robotics. So 2-3 days skeletal, because in 2 to 3 days time the skeletal muscle atrophies. In 2 to 3 day time the skeletal muscle atrophies, and this is not, I thought this was all nonsense and rubbish. I actually did a study, my study is there on PubMed, which actually says this. It actually says this, that you lose 0.5 centimeters of muscle equal to 0.5 centimeters of muscle in 7 days time. I have the study that says this. Okay, 0.5 centimeters. How much time does it take to create that muscle? I mean, it takes ages, years, 10 years, 11 years to create that muscle. it takes you just 5 days to get off that muscle. It takes 0.5 centimeter. I have found loss in 7 days time in intensive care unit. This makes it very difficult for them to balance. One fine day, if you tell the person, okay, stand up, it is not possible. Every day you tell the patient stand up, it will be possible earlier. You understand? Every day. Give safe but confident aggressive physiotherapy. I mean, it's important to have the consult of a physiotherapist in this stage. That is the reason that even though the patient has a ventilator, what do? We mobilize the patient. Every day morning when I come in the morning, it's very irritating to see patients on the bed. What do I tell every morning? You should be telling this. Before I come in, 6 o'clock, patients should be all sitting. Everyone should be sitting. When everybody is sitting, you know for certain these patients are going to do well. Okay, every patient should be sitting. This is the minimum you all can do when you are actually wanting to mobilize your patients. Minimum you all can do. When I'm not telling you go and do exercise with that patient. Minimum you all can do is make them sit on a chair. Make them sit on a chair. So before the morning over you are calling me up, you don't expect me to tell you mobilize karo, which is what I'm doing every single day. Every single day, whenever you call me up, my question is mobilize karo. Isn't this? Have you heard it? Have you heard it? So many times you heard it from me, right? So I should not be telling you this. You should be as doctors telling the person in the morning at 5 a.m. So mobilize karo, usko chair pe bitao. Once you tell them that, the patient is actually safe and sound. This is what happens. The patient starts getting better. So mobilization is very, very important. It has to be done aggressively. And you have to give exercise even with ET tube. Remember, deconditioning begins very, very early in course. Very early in course. Deconditioning is very early and reconditioning takes time. As I told you, I've had a couple of patients who come back to me after critical illness. A couple of patients. It's so difficult that after 9 months and 1 year also, they haven't gone back to their earlier muscle size. Because catabolism just keeps on occurring. Catabolism. But what I've noticed is, if you want to aggressively mobilize them, the catabolism reduces the speed. Catabolism reduces speed. Catabolism doesn't occur as much. You got the point? So, to avoid catabolism, reduce catabolism, the only thing is move. Move. That's very important. Move in whatever way you can. Move in whatever way you can. So, mobilization is very important. It's important that the patient has full support. You can't just say move the patient. You need to have support with you. Everyone together has to do it. So that patient gets the confidence of sitting. The moment patient loses confidence, tomorrow you will never move. Confidence is what you need to put in this patient. Reconditioning respiratory muscles will happen concurrently. Okay, at the same time that you mobilize, they get better. So the important points are avoidance of shocks. Very important points when you have mechanical ventilated patients. That's why I'm telling you that when you're putting central lines, ensure that all your shafts are in one bowl. All your shafts are in one bowl. All your shafts. So designate the bowl, and the bowl that you should use is the chlorhexidine bowl. Okay, put all the shafts either in the chlorhexidine bowl or in the normal saline bowl. Okay, put it in the bowl. Do not leave it on the table. Do not leave it on the table. You leave it on the table, it will puncture through the plastic. It will puncture through the way. No, you should not do it. It will fall down. Never and never keep a shaft on a table or on the patient. It has to be in a designated space. So it has to be in a bowl. Avoid shafts as much as possible. One of the most dangerous and grievous injuries that you can have in intensive care unit is shaft injury. Very, very important. And that is the reason that when you're disposing it, you are disposing it and not the nurse. It has to be disposed at site, at source. So you cannot say, I've finished it, okay nurse, aap rakho. Nahi. You are supposed to dispose it. So you are counting, you are disposing. That's why you should know where you're keeping your stuff. Avoidance of shafts, very important. Very important to introduce yourself. I failed one of my UK exams because I had not introduced myself. Okay, one of my exams. So it's important. You have seen me. What do I do? Every patient that comes, I first introduce myself. They may not need my introduction. They may know me also. Still, I will go and introduce myself. So you also should be introducing yourself. My name is so and so. I am taking care of you. I am the doctor here. You should know you're a doctor, not a nurse, not a respiratory therapist. You should know you're a doctor. So it's important that you introduce yourself. You gain the confidence of the patient. It's very essential. Introduce. Okay. Even if the patient is under sedation and paralysis, even if the patient, you never know, he may be listening. Sedation and paralysis. You still, I've done this every time I do it, and you have seen it also. Every time I do it. Okay, every time. Avoid unnecessary noise. So I did a study a time ago, around 8 to 9 years ago. 7 years ago, I think I did a study. It was there on the Times of India. If you would have read the front page, you would have realized that. Long ago, 7 years ago, the Times of the front page, there was a paper called Noise in ICU. There was a paper that came in the Times of India. It was a study that I did. Where what I did, I placed noise meters in our own ICU. our own ICU, I put noise meters. I put noise meters in our own ICU, and you will not imagine the amount of noise that was there. The amount of noise that we require in our ICU is 42 decibels. What we were is touching 100 decibels, 70 to 80 decibels every single time. So, making silence in the intensive care unit is a big task, and it's important that we all contribute to that. So, what is the protocol in our ICU? And these protocols, these we told you again and again. Of course, we never run through this, we never knew it. The protocol in our ICU is to not speak unless to speak only at a distance of an arm's length. The protocol in our ICU is to only speak at a distance of an arm's length. Okay, so if you want to speak from far, you have to shout, right? That should never occur only. You will automatically shout if you go to from the space. You are supposed to speak at a arm's length, so automatically you will be soft. Okay, this is the protocol in the intensive care. I want everyone of you to follow the same protocol. It cannot be more than an arm's length that you're going to talk. That is why when you're giving over, when you're talking, the first thing whenever you call me, what do I say? Alarm band karo, awaaz kam karo. You heard this so many times, right? Make it a habit. You will become better. Make it a habit. You will get better. Okay, you will become better. Make it a habit to talk softly when you're in the intensive care unit. Lifting patient with torn bed sheets, absolutely wrong thing. Never lift the patient with bed sheets. It can be quite disastrous. Patient can fall down and die. Between two beds, if there is a bed stretcher, there is a bed, you're transferring a patient. Don't lift through bed sheets. You will lift through a mobile device that is kept under the patient or a pad slide to move the patient. Do not use bed sheets. Apply the brakes always. Every single time when you are taking your round in the intensive, that's what the mark of a good intensive care doctor is. When he's taking the round, he's checking everything. He's checking whether it's all there, all done properly or not. And morning I come, I say, "Aage le lo, chalo brake lagao." You see that so many times I'm doing this. You're not supposed to do it. By saying apply the brakes. Simple things, but very important things. Applying the brake in the on the bed, very very important. Except during the procedure, the brake should be applied. That's why every time I come, I always check it's moving or not. The moment it's not moving, I say, "Kya nonsense? These people haven't seen." That's what it is. Apply brakes. Lifting attendance should be physically strong. You can't get a very thin-built person to help you lifting a person. It's very wrong. You should not do that. You should be understanding this. Is simple logic. But this is things that you don't understand. You still call any small lady a person to come and help you. It can be disastrous. No. Raise the side guardrails. Very essential. Avoid traction on lines, tubes, and catheters. So when you're looking at your lines, tubes, and catheters, ensure there is no traction. Okay, that's the reason you should be looking at the lines, tubes, and catheters because this may fly out. You can't do that. Okay, be very careful on tractions. Beware of hinge sections of the beds or doors. And daily watch for ECG lead source. Very difficult thing to manage. ECG lead source, whenever you're looking, auscultating, look at the ECG. If there is a change, discoloration around the ECG, means he's developed a sore insect. Take it off. And for the last couple of days, I'm seeing a lot of sores in the ICU. So probably you're not looking at it. Last couple of days, I'm seeing a lot of sores coming in. A lot of people are having red in the intensive care. Obviously, we are having a new set of nurses coming in, we are having a new set of doctors over here. There are problems that are occurring. Okay, the ECG source should not take place. It's a poor nursing and doctor care, healthcare, poor healthcare. It signifies poor healthcare.
In that
ECG.
case, we have to change the lead.
Correct. The lead positions. The lead positions. Ideally, they do it every day. Every day morning, they're supposed to open, rub, put it in a different place. They do it. But then, what I'm noticing is that they are probably not doing it. That's why you're having red. You see many patients having red. It's disastrous. It's an indication of poor healthcare. Very poor healthcare. Accident minimization is very important. As I told you, apply brakes and daily watch. Same thing that I mentioned over here. Lateral positioning. This position is very dangerous position. It can cause more amount of bed sores. That's why 2 hourly bed sore turning is very important. And when they're giving lateral positioning, the pillow position is extremely important. Where are the pillows? Between the knee joints over here. The lower leg is always folded, upper leg is always straight. Lower leg is always folded 90 degrees backwards, upper leg is always straight. Clear? You should have a pillow in these patients. You can't have no pillow on such patients. Okay, so if you look at a patient on the fasting BID, you are supposed to look at all of these things starting from first. You see pressure in the occipital region. You should look for eye care, for the sore over there, the central line, the oral care whether it's being done, and endotracheal tube care whether it's being done properly. Is the tube okay? Is the suction there? I do it on every patient that is on the ventilator. I do all of these things. Feeding, whether the feeding is going on properly. Where the incision site, if there is a surgery done, is that okay? ECG lead care, very very important as I told you. Peripheral line, if there is any care. Pressure sore prevention. A chest drain tube care. Foley's catheter care always needs to be fixed to the thigh. limb physiotherapy, thromboprophylaxis, whether it is done. So this would be a complete understanding of fast third BID. So if not easy to complete it, but you need to develop a skill that will develop over a period of time. You can't develop it overnight. I'm not saying today, but if you do it every single day you spend time on that patient and do it. By the 10th or 12th day, if you do it so meticulously, by 10th or 12th day, you will be at a situation where tuck, it's going. Okay, it takes time, but it happens. Provided you do it meticulously. Today, if you want to play a song, who plays the guitar here? You play. So, when you play the guitar, there are finger placements that you want to do. You don't get on day one, no?
Yes.
It takes time. It may take 20 days, it may take 20 days, it may take 5 days, 6 days, you don't know. But you start slow and then you go fast. Similarly, in any condition, you can't just drive at 100 miles per hour. You have to do it every single day. When you do it every single day the way you're doing, you will get better. In intensive care, you don't need to be actually Yuvraj Singh. You need to be actually Rahul Dravid. That is how it is. If you are very good, even if you are doing the same thing again and again, you are 99%. You are 99%. You understand? You don't need to do one day 100% and the other day 50%. That is wrong. You understand? You have to do it. The daily movement has to be the same meticulous movement. Intensive care, you can make it difficult for yourself. Why are we all here? To make intensive care easy for ourselves. And to make it easy, you have to do the same things, the same times again and again. Same thing. Don't consider it. Same things, same time, again and again, meticulously, and you will probably get better. Alright. Any questions on this? On this? No, right? Okay, chalo.